So this is an interactive session, and you can stop me at any time and ask any question. So the basic aim is to mutually share the retrograde approach and to teach you how to go step by step. So I have selected a case to present. यार वो slide. So this was circumflex CTO, which was initially attempted antigradely, but the wire went subintimal. Although the ideal approach would have been to do an antigrade dissection re-entry, but as we don't have that facility available with us, so we had an option of retrograde, so we decided to go retrograde on this case. So these are the simultaneous injections. So you can see an epicardial collateral, quite a tortuous epicardial collateral connecting the right coronary artery to the circumflex. And there is not much segment that is missing. As I already said, that ideally an antigrade dissection re-entry would have been quite useful because there's a nice landing zone in the circumflex. So we are using a 7 French guiding, which is a Judkin. We are using a balloon in the conus branch to increase support. This is a Corsair catheter, and so the next, we entered the collateral channel with the microcatheter and gave a tip injection. So this is a Sion black. Sion black is basically a soft-tipped wire. It has a hydrophilic coating with a polymer jacket, so its tip is very soft, about less than 1 gram. So we crossed with the Sion black and advanced the Corsair in the circumflex. So finally, we had some difficulty in taking the Corsair up to the left main, and but finally we were able to get the Corsair through the circumflex. And this was a lumen-to-lumen tracking of the wire. So the wire tracked easily, and we sort of, now at this point in time, we were unable to externalize the wire. We changed to workhorse wire also, but the wire sort of wouldn't cross into the antigrade guide. So we took a guide liner to sort of help externalize the wire. But after a lot of effort, we couldn't externalize the wire even with a guide liner. So you are free to ask any questions or stop me at any time. So this is an interactive session. Oh, sorry, I'll explain. So by externalizing, we mean that we want to make a connection between the retrograde guide and the antigrade guide. So the catheter needs to enter this guide catheter so that we can put the wire, and then take this wire out from the femoral in which this guiding is placed. By externalization, we mean that we take the microcatheter into the antigrade guiding and then take an RG3 wire all the way and take it through the guide cath and externalize it through the femoral artery. So you make a loop of the wire starting from the retrograde guiding into the antigrade guiding and then outside through the femoral. So that is what is meant by externalization. Ji, please. That's a very good question. Actually, I was not doing the antigrade case. I was called once the antigrade guys had failed, and then they called me that whether a retrograde approach is possible. So I was brought into that stage in which they had started the retrograde. So probably they tried different wires and the wire went subintimal. Although you are right, we could have tried many other things like the parallel wire technique or different wires, which I am sure they must have tried before calling me to do the retrograde. Sorry, sir. The question was that why was the anti-grade approach abandoned? What was the reason that we went retrograde? So the reason was that there was another operator who was doing it, and so it was done in the same setting. Yes. Sorry.
What thing should we see in order to decide that we are switching from anti-grade to the retrograde approach? Just in the journal, sir, if you can.
Well, this is a very good question because nowadays you should try and do a CTO anti-grade as much as possible. The reason being that there is a lot of data coming which shows that the complication rate in the CTO when you do retrograde is very high. So it should be a last resort. And when you are doing a retrograde, you should go for septal collaterals first because they are safer as compared to the epicardial collaterals. But an epicardial collateral like this, it is a very large collateral, so you can do it safely, but I agree that sometimes you can have more complications with retrograde PCI.
So what did you anticipate in this case? Why was the externalization quite difficult? Whether the wire was, if the wire is in the lumen, it should go into the guide. I mean, is it subintimal? What were you thinking? And why did you take the guide liner? What was the reasons behind that?
So what I think was that it is basically the angle of the guiding catheter that sort of prevents the wire to enter the guide cath. And by introducing a guide liner, you sort of might change the angle a bit, and it goes a little bit wedged into the left main. So you might be able to sort of put the wire in that guide liner. But we were not even able to put the wire back even after this. So there was, and that was the next step. So this is just to demonstrate that all these things are possible. So what we did was we first took out the Xeon black, put an RG3 in. An RG3 is a wire which is 330 centimeters long. So it is used to externalize, and it's very easily pushable and maneuverable. So, and because if you want to snare, it has to be a long wire, then you have to pull it back through your anti-grade guiding into the femoral artery. So we were able to snare the RG3. This is we are snaring. And I think the anti-grade guide was in the radial, so that's why you saw the snare catching on the.
So before externalization, is it worthwhile, I mean, trying the reverse card? Maybe you can get, for example, the distal wire can act as a marker, then you can do anti-gradely. Is that a possibility?
Yes, that is a possibility. So reverse cart, as he has mentioned, that is the usual approach that we take once we are doing a retrograde PCI. But in this case, our wire was luminal throughout. From the retrograde Corsair to the proximal cap, our guide was luminal. So once your wire is luminal, then there is no point in doing reverse cart. You do reverse cart only when your wire is subintimal. So you take your anti-grade wire subintimal and then do a ballooning and sort of re-enter from the retrograde wire.
Which Corsair did you use? Because you know that there are two Corsairs. One is 135 length, one is 150 length. For retrograde, you need to use the 151, not the 135. 135 is cheaper. If you're using anti-grade or whatever reason, that's one. But if you're doing retrograde, you need to use the 150.
That's very important. So this is a very important point he has raised, that all microcatheters come in either 130 or 150. So for a retrograde approach, you need a 150. And another thing is that once you are using an epicardial collateral, you need to shorten your retrograde guide also. Because if you don't shorten it, so you will not be able to externalize the wire. So you need to shorten your guide by 10 centimeter also. Uh, Ideally speaking, from retrograde with an epicardial collateral, Caravel is probably the best because it has the lowest profile and least traumatic. So if you are doing but at that particular time when we did this, it was a few years back, we didn't have Caravel at that time, but now we use a 150 Caravel if we are using an epicardial collateral. It is the smallest profile microcatheter, least traumatic. And the wire should not be Xeon black. Ideally, the wire should also be a SUO03, which we don't have for an epicardial collateral, which are this tortuous. So now we have externalized and completed the loop with the RG3, and we have pulled back the Corsair catheter. And this is, faintly you can see the RG3 wire. So now we have a whole loop. The wire is coming from the retrograde guide into the antegrade guide and out from the right radial artery. So we balloon the circumflex. And this is after, but the case is not over. So you have to take a picture of the donor vessel because although we were monitoring the ACT, but somehow there was thrombus formation in the donor vessel. It is possible because we had a wire in the conus branch as well as in the, so this is how it looked like. Although the patient was quite stable, but we first ballooned it with some suboptimal results, so we had to stent this portion. Maybe it was a dissection or a thrombus because our ACT was always optimal. And the other thing is that it's very important that you should monitor your ACT every half an hour, and it should be above 300.
What precaution would you take to avoid the cheese cutting effect? For example, pulling up the donor.
Yes. So this is an important question. What precautions do you take to prevent the cheese? So you keep your microcatheter inside the epicardial channel throughout the procedure, so it is protected. So the wire doesn't touch the collateral. So that's how you keep it protected. And always remember that bad thing happens when you pull. So once you are pulling on the RG3 or the microcatheter, the guide will get sucked in. So you have to disengage the guide. Whenever you are pulling any equipment in a CTO PCI, always remember that when you are withdrawing, bad things will happen. So always take your guide, disengage it completely, and then pull.
Once you externalize the RG3, do you reverse it in order to incorporate other balloons or wires, or you keep it the same with the soft
We keep it the same way. We keep it because it gives a lot of support.
Right, but many a times when the tip is out, it's so much mangled that you can't actually introduce balloons or wires.
You are right. But in that case, if you have made a path, you can take an antigrade wire and sort of place it down and then take out the RG3 and use the antigrade wire.
You can't use a microcatheter to actually go into antigrade?
Yes, you can do that. Yes, you can do that. You can take a microcatheter. If your RG3, he's right, your RG3 can get damaged at the tip and it's very soft, so you are unable to take any catheters or balloons on it. In that case, you take a microcatheter, change it with another wire antigradely, and then do your complete your procedure. यार वो जो दूसरी presentation है वो इसी के साथ है नीचे. So यार ये फिलहाल चल रही है या ऑफ हो गई? चलो ठीक है. So it was quite an optimal result after this. So yes, very important. You should have covered stents and coils of all sizes, and you should be familiar that the coils you are using are compatible with your microcatheters. And most of the coils we use fine cross or Caravel, so the coils that we have are usually compatible. The Cook coils, so they are usually compatible.
Do you have any experience with fat embolization? Kind of you don't have coils in microdissection occurs in one of the smaller vessels, the collaterals.
Not really. So does anybody have experience with fat embolization?
At times they keep clotted blood just to make
Yes.
sure.
Okay. So all these things are doable. Some people cut a balloon and then sort of push it distally in a distal perforation. But I believe the most reliable method is putting in a coil, because then you are sure that this will occlude. Yes, this is mainly for distal wire tip. But the coils can be used for these collateral perforations because they can be very difficult to treat. So you have to coil them from both sides, because the collaterals are coming from this way and that way. If you don't coil them from both sides, they'll still keep bleeding. So this is, so you can select, sorry. Sir, if you have a perforation of the epicardial collateral, we do, yeah. Otherwise, I agree with you. Yes, sir.
Epicardial is fine, but otherwise, I think because everything cost. So, sorry, everything cost. I think balloon tamponade sometime works. I think you should try that because it's cheaper. Your balloons are already out. And if it works, fine. Not for epicardial, I agree. The epicardial is risky because of tamponade.
But again, he's got a very valid point. Once you've got a perforation of an epicardial collateral, you first do balloon tamponade to stop the bleeding until the time you take another guide. So balloon tamponade is even vital, even if you have to put in a coil. So you do a balloon tamponade and try and avert an emergency and slow down the bleeding, take another guide, do a ping pong technique, and then sort of, if the bleeding is very, it's a large perforation, so it is better that you take another guide and sort of put the coil. You can, yes, take another. And then, yes. Normally you have 7 and 8 French guides in CTO PCI, so you can take through that guide 2 bits of equipment. Yes, that's very important. Yes, yes. So balloon tamponade is very important. Yes. Yes. So why would you think of retrograde? This was the initial question as well. So it's very important to do a dual catheter angiography. And once you do a dual catheter angiography, if you have an ambiguous proximal cap, you don't have a good distal target, the length of the CTO is greater than 20, so there are very less chances that you will be able to succeed antegradely. So you will have to proceed via the retrograde approach. So the retrograde approach can be through wire escalation, as we did, or through reverse cart, which is subintimal dissection and re-entry. So again, the same things, proximal cap ambiguous, long lesion, poor distal landing zone, and this is another important point. So if your distal cap is at a distal bifurcation, so if you do an antegrade approach, you might lose one of the side branches. So you have to go retrograde if you want to prevent side branches in such a situation. So this is an additional point that will sort of let you go towards the, so this is an RCA CTO. These are bridging collaterals, and the proximal cap is ambiguous, the root is ambiguous. So although nowadays, if you have a good landing zone, antegrade dissection re-entry would be sort of preferable, but you can think of retrograde in this case as well. So all you need is skills and equipment. There is a steep learning curve because you have to sort of be proctored and assist a lot of retrograde CTO cases to be doing them yourself independently. And definitely, there is more potential for complications. But in experienced hands, it's a safe and efficient procedure, especially the Japanese operators. They are very good at doing retrograde. So now, how are you? So planning is very important. And you have to do the septal channel analysis, which you will be using for a retrograde approach. Then you cannulate the septals. Then you advance your wire and corsair in the septal collaterals. So you cross with a wire into the CTO. Then you cross the corsair after the wire. So you advance it to the CTO, externalize, and then balloon and stenting. So these are the various things we'll be discussing one by one. So ACT is very important. Keep your ACT above 300 whenever you are doing a retrograde approach. Again, the point I was saying that whenever you are removing the retrograde equipment, the donor guide will be pulled forward. Always remember that bad things happen when you are pulling the equipment out. So be careful and always disengage the guide before you are pulling the retrograde equipment back. So dual catheter injection is almost mandatory. Only in cases in which you have ipsilateral collaterals that you don't need dual catheter injections, but 99.9% of the times, dual catheter injections with guides in both the antegrade and the retrograde systems. You should take an unmaxed view so you can see all the collaterals. There should be no panning, and there should be long runs so you can see all the collaterals filling. So now septal collaterals are probably the safest because they travel in the septum, and even if they perforate, there is a septal hematoma which is usually not very hemodynamically significant. So here you can see the septal collaterals from the LAD connecting the right coronary artery. Here is a very tortuous epicardial collateral which is also connecting the circumflex to the right, but these would be sort of very dangerous collaterals. So if in the presence of septal collaterals, you should not go for these. These should be the last option and only be done with specialized wires, that is SUO03 wire, but otherwise you can end up in perforation and they are very difficult to treat once they perforate. Here you can see these septals, small septals connecting to the right coronary artery. Sometimes you don't even see the collaterals and some people recommend septal surfing, in which even you can cannulate with a Sion black wire in collaterals which are even not visible. So, but the preferred approach, especially when you are starting a procedure, is to take your microcatheter down, take a picture, and visualize the path of the collaterals in which you have to take the wire. So that is a more assured way of succeeding. So you can have septal loops. This is septal loop connecting to the distal LAD. So these are ipsilateral collaterals. So you can come through this collateral, go back into the LAD and do a retrograde PCI. Again, these are collaterals from LAD to the LAD. And this is the very tortuous sort of septal loop here, you can see. So the epicardial collateral. So initially, they were very feared collaterals because they can cause complication, rupture easily. And nowadays, people can safely do with epicardial collaterals, but always start off your retrograde program with septal collaterals which are safer. And once you have gained experience, then you can shift to the epicardial collaterals. So the epicardial collaterals, here you can see this is the OM branch, which is almost connecting directly to the right coronary artery. And these are collaterals in the AV groove. So this is an AV circ, which is connecting to the right coronary artery. And again, these are small collaterals which are connecting, and here we can see some. So what is an ideal collateral which we need, which would sort of help us? So the angle at the donor site should be greater than 90, so you can easily pass your wire in. So the collateral should be clearly visible without any branches, tortuosity. But in the real life, this does not happen, but this is sort of an ideal situation in which in the retrograde vessel you have greater than 90-degree angle where you are entering back into the donor vessel.
Do you have to balloon the collaterals at times as well?
Yes, yes. If you are unable to take your microcatheter doesn't follow the wire. So with a small balloon, you can gently inflate the septal so that, yes, definitely, that's very important before.
तो इंजेक्शन थ्रू माइक्रोकैथेटर देना
जी जी आप लेकिन यू नीड टू बी श्योर कि माइक्रोकैथेटर आपका ल्यूमन में है. आप पहले पिक्चर ले लें नॉर्मल गाइड से अगर माइक्रोकैथेटर ल्यूमन में है. द एडवांटेज ऑफ डूइंग एन इंजेक्शन फ्रॉम द माइक्रोकैथेटर इज दैट you reduce the dose of contrast. But another thing is that contrast is a very viscous sort of substance. So whenever you inject the microcatheter to take a picture, use saline and inject it again, so the saline clears the contrast, which is the residual contrast in the microcatheter. So it is cleared with the saline injection. So it's very important after every injection you give saline. If you don't, then your microcatheter will get clogged and you won't be able to take wires through that. That can also be tried. Yes, yes. That is also a good trick. Yes, obviously. You are injecting in a very small vessel. So if you inject with force, you can dissect and perforate. Yes. These are very important tips what he is mentioning. Yes, absolutely. So be gentle whenever you are doing, don't force anything. And also another thing is that perforations usually don't happen with wires, or even if they happen, a wire perforation in a collateral is usually not that dangerous. But it is when you push your microcatheter, if it is not going, don't push once your microcatheter is not going. Find out a reason why your microcatheter is not going. And try and take a microcatheter which you can rotate, because Caravelle and the fine cross you can't rotate. You have to push. And at times pushing is not adequate. So Corsair or Turnpike catheters you can rotate. So by rotation, so that you can reduce the friction. And try not to push the microcatheters, because that's when the problems happen. So this is the normal bend of the workhorse wire, because you use a workhorse wire to reach the collateral. And after engaging into the microcatheter, you need a short tip to sort of for collateral crossing. Now you can do the same principles apply to retrograde wire escalation which apply to antegrade wire escalation. So you have a small CTO, less than 20 less than 20 millimeters. So that would, you can use a retrograde wire escalation. But if you have a long segment CTO, then reverse cart is probably a more efficient way of doing the CTO technique. Now, once you do the retrograde wire escalation, so you want to pass the wire from lumen to lumen, no subintimal tracking. And this is probably the ideal way of doing it, but most of the times you are not successful. So in that particular case, you do reverse cart in the body of the CTO. So you try not to go subintimal in a normal vessel. Try to be subintimal only in the body of the CTO because it's already occluded. And otherwise, if you go proximal or distal subintimal, you can lose side branches which come in the way of that particular area. So true to true wire selection, short CTO, well defined. Usually so for the retrograde approach, the proximal cap, this becomes the proximal cap because you are coming from distal to proximal. So this is usually well defined and tapered. The proximal cap in a chronic CTO is usually ambiguous because it is exposed to systemic circulation pressures, which leads to fibrosis in the proximal segment of the CTO. So retrograde wire escalation in short and well defined. So if you have long CTO or it is poorly defined, then we go for retrograde dissection and re-entry. So this is how you do retrograde dissection re-entry. Now you have come. यार ये कोई और मिल जाएगा पॉइंटर जो है कोई हाँ ये ठीक है. So your retrograde wire, you enter the subintimal space. So you can enter the subintimal space normally as well, or you can knuckle your wire and go subintimal. And same can be done from the proximal side. Both wires are in the subintimal space. You increase the subintimal space by inflating a balloon, and then you redirect your retrograde wire towards the balloon because it will sort of decrease the space between the two wires. So before doing that, you need to be sure in two orthogonal views that both your antigrade and retrograde wire are close together. So they should not be very far apart. So your wires are close together, then you inflate an antigrade balloon and redirect your wire towards the balloon. So it usually enters, and this is a sort of a guideliner which you have brought forward into the subintimal space. So this wire cannot go any place else. So you will also, once you enter here, you will also externalize the wire easily. So your microcatheter can follow in here, and then you can change to an RG3. So this is the same shown in a cross section. So this is the lumen, both the wires are subintimal, and then when you inflate a balloon and you redirect both wires in the subintimal space. And you note that these only the segment of CTO is involved in this subintimal tracking. So there is, you try to minimize the area that your wires go subintimal. So this video is not playing, but the thing is that both your antigrade and retrograde wires and equipment should dance together. So this is a feature that tells you that your wires are in the vessel architecture and both are in the same vessel. They are not out of the vessel. So this is a very important question. whatever wire you are using for crossing the channel, for example, you are using a Xeon black, try and take the Xeon black as much as possible retrogradely if it goes. So if it goes smoothly, very well. If it doesn't, then we shift to a polymer jacketed wire. So that is, the advantage is that you can knuckle it also, and you can take the knuckle up till the proximal cap, then anti-grade. The other thing is that sometimes you are unable to puncture the distal cap with a polymer jacketed wire. Then you have to take a stiffer wire, most likely a Gaia third, to puncture the cap, and then you can sort of take the... Yes, yes. Umar, Dr. Umar. Please, please, please. Sir, sir. Mic carry karo. Sir. Sir, sir. Sir. Sir, post cabbage patients are more difficult CTOs. That is the question rather than normal CTOs.
Right, yes. So what was the question, sorry?
I found them more difficult to do it, and they need to be more carefully to be done.
Yeah, definitely, because most of the time they have heavily calcified. They are heavily calcified, this is number one. And number two, they are mostly very long CTOs rather than, and we have mostly epicardial collateral rather than septals. The other difficulty to deal with the epicardial collateral is much more difficult. So, and complications is more, of course. Yes, I think it's true. Most we consider a post-cabbage CTO as a complex CTO most of the time. It's a complex CTO.
You showed the picture of post-cabbage, and again, if they develop a tamponade, they're massive. They're also nightmare to treat because they have a pericardial adhesions, whatever, they get a localized tamponade. So whenever you select a case, people need to be careful. I think I am, although my hair has gone gray, but I'm still careful.
Yeah, very important point. When you do complications, you do local tamponade, and you can't do nothing in the operation. Yes, it's a very difficult situation if you have.
More slides. Yeah. Yes, that is a good point. Using the vein graft as a conduit
yes.
for...
Very good point. Yes, especially if you very degenerated vein graft, it's very good collateral. It's easy to cross. If you have occluded one, that's also good. You can not that difficultly cross occluded graft. That's another option. Yes.
Would you prefer doing this, the PCI to the graft, or you would try to open the CTO?
Definitely CTO. But of course, we have to check the how age of the graft. If it is really old, much more than 6, 7, 8 years, I think you can go. Yeah, definitely. Yeah, true. Okay. Hi, Naif. So,
Umar, you can have a seat. We'll sort of continue the discussion. So, you must be knowing Dr. Umar Goktekin. He's a renowned CTO operator. He does lots of live cases, and he'll be doing live cases tomorrow as well from AFIC. So, he is part of our PSIC and part of AFIC as well. So, he's a tremendous guy and a great expert at CTO.
Thank you. Thank you very much. It's an honor for me.
So these are the challenges in reverse cart. So if you have both the wires that are subintimal, that is not a problem because you can then connect both the wires by inflating a balloon. But if you have an antigrade wire that is luminal and retrograde wire subintimal, or the other way around, the retrograde wire is luminal, and so then the connection is a bit difficult. And you can sort of diagnose these problems by IVUS. So this is what is being shown, and the various possibilities of antigrade and retrograde positions of the wires in the reverse cart. So could you sort of, Umar, explain a bit about reverse cart and the problems you can?
Yes. So mainly why we do reverse cart, when we try to go from the retrograde side, okay, we have to our wire have to be in true lumen at the proximal part, proximal to the CTO, right? Sometimes it's difficult because the best scenario for retrograde, your wire can easily cross the CTO interluminary. It's sometimes happens, right? Your wire can cross through CTO and then proximal lumen. You will push your microcatheter, you will change your wire, and you have a loop. But it's not that often. Mostly we have from retrograde we go either intimal or subintimal space. In that time, not easy to find proximal true lumen. So, did you show the some pictures regarding reverse cart at the beginning?
No, not
So
really.
how we do it?
No.
I'd like to draw here shortly. For example, this is RCA. We have occlusion here. Occlusion. And this is distal. So our wire can go, the first scenario can cross it easily. The second one stay here, stuck here maybe, okay? Or even if it goes subintimal up to ostium, that's another scenario. So we have to cross the lumen, right? How we do it in that case? This is the logic of reverse cart. We send a wire from the proximal. We don't care if it is interluminar or subintimal. We don't care that much. So we'll send a wire to distal up to here. Of course, if it is crossed the lumen, that's fine, but it's not the case. Most of the time, stuck somewhere. And we do, from over this wire, we do ballooning here, all right? We have a space here with balloon. We have a space. It could be intraluminar or subintima. So this space, after ballooning, will have contact directly to the lumen. That's the key. This balloon in contact with the true lumen. So we try to cross from retrograde to this space. Okay, enter this space. If we cross this space somehow, this space will bring us directly to the lumen. That's the logic why we do reverse cut, why we do balloon inflation. We like to have a space to cross. Okay, the most difficult scenario is our wire retrogradely subintima, antegradely intima. This is the most difficult scenario. Others are easier. The easiest one is both of them in subintimal space. It's more easy because subintimal space easily connect each other. Okay. Do you have any questions regarding this? Because this is very important to understand why we do ballooning.
Just a simple question. If we balloon in the subintimal space or if we push a guideliner in the subintimal space, does there is increased chance of vessel perforation or any special precautions to be taken in ballooning in the subintimal space?
No, not really. You know, if you are not very big with the balloon, for example, if the vessel is say 3.5, but you deal with the 4.5 balloon, you might have a rupture. Otherwise, if the vessel is 3.5 and you do dilatation by 3.5, it's really safe. Or you pushing guideliner or extension guiding is also safe. It's not easy to do perforation when you deal with this because subintimal space easily become enlarged. Yeah.
There is any chance of intramural
Yeah, of course. I mean, yes. If you do ballooning, you will have hematoma. Yes, yeah, yes, 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 yes. If you do ballooning in the subintimal space, you will have, of course, hematoma there. Yeah, yeah, yeah. Of course.
Umar, I have one question. So you said that the most difficult situation when your antigrade wire is luminal,
Yeah.
and your retrograde wire is subintimal. So how do you tackle that situation and fix it to
In
make
that
your
case, yes, very good question. In that case, what we do, in that case, we try to go use a bigger balloon to have, dissection at the true lumen. If you use bigger lumen, you might have dissection. So then there will be connection between true lumen and the subintimal space. Better to use bigger lumen, a bigger balloon.
So you create a dissection with the antigrade ballooning, and then take the antigrade wire into the subintimal space. So then both the wires are in the subintimal space, and then they can connect. So in a scenario in which you are unable to connect.
How you will manage this? If you are trying to cross with your microcatheter, you have a difficulty to cross it. So if you take support for wire or balloon.
Yeah, very good question. And sometimes I think to me, one of the most difficult part is insert the microcatheter for retrograde CTO. Yeah. So what can you do? You can anchor the retroguiding to have better pushing, or you can change your microcatheter, because sometimes microcatheter could be tired if you use it 1 hour, 2 hours. You had better change your microcatheter. You can, for example, there are more sportive microcatheter like Corsair or Turnpike. They have more sportive microcatheter. They can choose one of them. And if you think that there's a friction through collateral, septal collateral sometimes could happen, you can do gentle dilatation in the septals. You can do 1.5 dilatation. It may help you. Those things you can do.
Have you observed the perforation while you are using the stiff microcatheter if you have a difficulty?
Yes.
Initially to cross it?
Yes. Yes. If you do with the septal collateral, if you push more, right? If you push more microcatheter through collaterals, you have perforation. You will have perforation, but most of the time, septal perforation is benign, but it could be also dangerous. Of course, you have to follow the patients. Easy to perforate collaterals, I would say. We have to be careful. That's why what I do, I don't want to push. When I try to cross the, sometimes what happens, what could happen, you have, most of the time you have, this is one of the most difficult part, right? When it's difficult to push a microcatheter, sometimes what you might have, for example, you might have this kind of for example, LAD, RCA, okay. Sometimes when you push your microcatheter forcefully, your microcatheter, like this, for example, it became like that suddenly. It means that you perforate collateral, right? You have to careful. If there is angle like that, you have to check this angle. If you push more, you will perforate, and your microcatheter will be like that. It means that you perforate. You should know that it's perforated. And if it's really difficult to push it, especially from this area, you had better do ballooning, dilatation. You can't dilate epicardial collateral, but you can dilate septals. That's what I want to say. But this is a difficult scenario, to be honest.
Slide. So once we have crossed our wire into the, across the CTO, so we can either take the wire directly into the guiding catheter, or if that is not possible, we can take a guide liner in, and that will sort of wedge into the CTO and help our wire be externalized. And we had just, if even that is not possible, you can snare also a wire in the aorta. So stenting must be done optimally. And
So for the snaring, first of all, we should never use O14 long wire. We have in the market, we have O14 3-centimeter wires, right? Fielder has it, and Pilot has it. We never use them. Never use O14 wire for externalization. We always has to use O10 wires. This is very important point. If you use them, you will have definitely problem. Yes, and serious problem. Please don't use them. Don't think about them. And secondly, for snaring, we don't like to snare CTO wires. Yes, we can snare RG wire, externalization wire easily. That's fine because you will pull them. That's fine, but we don't like to snare, for example, Conquest Pro Gaia wires. Why? Because when you snare them, there will be kink, and sometimes it's not possible to release from the snare. You can have microcatheter into aorta, which is okay, but then you cannot release your wire from the snare. Okay, so it's possible. It happens. We don't like to do it. You know, you can, yeah. Hydrophilic wire, to snare hydrophilic wire is, you know, I would say it's also not, shouldn't be option, but if you do it, release of the hydrophilic wire easier than Conquest or Miracle or Gaia. Never snare them. You have to be very careful about that. You have to, somehow you have to push your microcatheter into aorta, and you change your wire with RG wire, for example, and then you can snare them. And snaring, not sometimes easy. You may spend 5 minutes, 10 minutes sometimes. It's not that easy. Looks easy, but you know, in the operation you will see it.
So there is another technique, Umar, that you can sort of withdraw your antegrade guiding into the ascending or the arch of the aorta and take your RG3 and sort of engage into the guiding catheter without snaring it. Yes. So this is another thing that is possible.
That's true.
And the point that he's making is very important, that only externalize with an RG3, which is an 010 wire. Normal CTO wires are available in longer lengths, 014, don't use them to externalize. And so, rota can be used, yes.
Rota can be used, yes.
Yes, because it is an 09, I think, rota is 09, yes. So rota can be used. And the other thing is, don't snare the stiff CTO wires because you won't be able to disengage them from the snare. So these are very important steps which can lead to complications. So stenting must be done optimally, and IVUS, I think, should be done to sort of optimize your stent size and your stent approximation with the vessel wall. And so again, bad thing happens when you are removing the equipment. So be very careful, and whenever you are pulling the retrograde equipment, the donor guide gets sucked in, and it can cause dissections and problems. So always disengage your guide whenever you are pulling back the equipment, and remember that bad things happen when you are pulling on the equipment. So in the conclusion, these are multifaceted procedures. Many skills need to be learned, and it's a very steep learning curve. And during the initial part of your program, you need proctoring, and especially you need to assist senior operators in order to learn the various things, and it's a very vital component of any CTO program, the retrograde PCI, and in experienced hands, it is safest and a very efficient way to treat a CTO. Thank you very much. We still have few seconds for questions.